Good afternoon, members, and to the viewing public who are watching through our social media platform. The chair will now call this budget uh, hearing today with the Commonwealth and Healthcare Corporation to order. And with that said, we move now to let the record reflect that with four members present, we have duly established a quorum. So with that, we are now in item 2, adoption of the agenda, and do I hear a motion? There is a motion to adopt today's agenda, and it has been seconded. Discussion on the motion, ready? All those in favor, please say aye. Those opposed, say nay. The ayes have it, motion is adopted. Moving along, we are now on item 3, public comments. So at this time, are there any members of the public who are here with us this afternoon that wishes to make comments? You may do so right now. Seeing that there is no members of the public to provide oral testimony, we move further down on our order of business, and we are now on item 4, introduction and statement of the chair. So at this time, the chair would like to welcome you, Madam CAO, and with your CHCC team. Welcome to your chamber, and thank you for coming before this august body to discuss the corporation's budget request and also the governor's proposal that was submitted to the legislature back in April 1st. So with that, let me recognize and introduce the members of the Standing Committee of Ways and Means who are present here. And some of the members will be joining us shortly. So let me start with myself. I am J.P. Sablon, Chair of the committee. And to my left, we have Representative Roman Benavente. And in the other side of the aisle, we have Representative Denita Yangtamay. And to her left, we have Leader Roy Ada, who is here too as well. Assisting our committee this afternoon is our bureau staff, starting with our legal counsel, Joe Hallahan. We have our budget analysis, TG Rabago. We have our IT, Mr. Jonathan Diaz. We have our Sergeant at Arms, Mr. Pete Tuwai. And also will be assisting us this afternoon is our senior legislative assistant, Ms. Claire Sablon. And just joining us right now is a member also of the committee, Floor Leader Marisa Flores. So with that said, Madam CEO, at this time, I give you the floor for your opening remarks. Thank you.
Thank you, Chairman and members of this committee, for this opportunity to speak to all of you regarding our budget and especially accommodating our request to have this hearing a little earlier than is planned. I would like to introduce my team, of course. We have our COO for Ancillary and General Support Services, and with Mr. Jesse Tadella, Dr. Jesse Tadella. We also have our Chief Strategy Officer, Eleanor Cabrera, our Deputy CMO, Chief Medical Officer, Dr. Marty Rohringer. And to my right, I have our CFO, Perlita Santos. And further there is we have our Chief Operating Officer for Quality and Patient Safety as well as Business, Ms. Tiffany Crisostomo, and our Acting COO for Population Health, Ms. Heather Pangilinan. And let me just turn it around. And right behind me, I have our wonderful and amazing staff of CHCC family. So they're here to present and to be here as a support. Sorry about that. Oops. So I'm going to start with, we understand that these are challenging times, and I know you heard this so many times during this budget hearing. And we just want to express that we witness it every day. When patients struggle to attend their crucial follow-up appointments, we step in to help them purchase even transportation vouchers. We have broadened our sliding fee scale to include additional tests necessary for accurate diagnosis, as without these, patients may not receive the care they need. We have also advocated for patient coverage when insurance companies deny essential services. We recognize the difficult choices individuals face, often having to decide between their medication and meeting other basic needs. Our budget, excuse me, our budget was developed based on insights from our managers, the people behind me, and many in the operations who are passionately advocating for the needs of our patients and residents. We have also employed future-oriented thinking to ensure we remain available, accessible, and affordable, with our workforce being the core of our strength. Examples include investing in local providers to provide pain management services for the first time in the CNMI, and looking at how CHCC can partner with other hospitals to bring costs down and leverage other benefits of a public-private partnership. In addition, our Grants Management Office is actively pursuing funding opportunities to equip our workforce with the necessary tools and skills, including the implementation of a robust electronic health record system that not only meets the class award standards, but also complies with TEFCA. As we present to you today, you will see that our pursuit of growth is not just driven by the desire for expansion, but rather by the genuine needs of our community, along with having the long-term vision to make changes to ensure our resilience. Before we proceed with our presentation today, I want to thank you all for your support and partnership. Your support of policies that address shortfalls in funding help us ensure our lights remain open for our community. We are grateful for the time given us discussing how changes in policy can help. We also know that you're aware of the minimal funding that we receive annually, but like others, we ask that you provide us the support we need to deliver quality health care to our people. We've done so much with so little. Just imagine what we can do with more. So I'm going to turn it over to our CSO, Ms. Eleanor Cabrera, to present this PowerPoint presentation. Thank you for the time.
Hafere Tiro Chair Sablan and members of this House Committee on Ways and Means. Thank you for the opportunity to provide updates, information, and also the opportunity following this presentation to ask any remaining questions you may have of CHCC. For the record, as CEO mentioned, my name is Eleanor Cabrera, and I serve as the Chief Strategy Officer for CHCC. Chair, may I start?
Yes, please proceed.
As an overview, it is our hope that as we go through this presentation, a few key messages remain with you. That CHCC has kept resilient through some very difficult times. That we have kept open essential lifelines and services through persistent challenges. And that in addition to being a health anchor, we have also been an economic one for our Commonwealth. Despite challenging fiscal environment in recent years, including a Medicaid funding crisis in fiscal year 23, CHCC has worked diligently to stabilize finances and protect access to care. We remain the only hospital and public health provider in the CNMI, serving patients across Saipan, Tinian, Rota, and through mobile clinics. In 2024 alone, we delivered over 124,000 patient encounters. Since 2019, CHCC has grown revenues and invested in services, nearly doubling patient revenue. Expenses have risen too, but stabilized by 2024. The positive change in net position in 2024 shows progress after pandemic-era deficits. Related debt and the general fund deficit remain concerns, but overall, CHCC's financial picture is strengthening. It is always important to note that at CHCC, expanding services for our community require an increase in expenditures. Here we have some data regarding our CHCC encounters, total encounters by location across our emergency department, hospital admissions, our clinics, and our health centers. Our ability to keep all our doors open and keep healthcare local with expansions in clinics capacity doesn't just serve health needs. It supports family stability, prevents off-island migration, and gives residents confidence that help is here when they need it. As you can see from the data, we've experienced some outpatient shift. We have total encounters up 46% since 2019. Our family care clinic, for example, is up 60%, as well as our ED visits. This reflects a growing reliance on ambulatory care and the need for sustained clinic capacity. In 2024, the Off-Island Referral Program, our Health Network Program, or otherwise referred to as HMP, processed 943 cases, with about 75% of these referrals completed successfully. The most common specialties included cardiology, radiology, ENT services, oncology, pediatrics, and orthopedics, reflecting continued gaps in our on-island specialty capacity. We, through the HMP, face barriers like airline medical desk reviews, limited air ambulance resources, and visa delays, which impacted transfer times. Equity challenges also remain, with some patients unable to travel due to income or insurance coverage limitations. These patterns highlight why meeting funding mandates for the Health Network Program and continued investment in local specialty services is so critical to reducing reliance on off-island referrals, as well as reducing CNMI Medicaid dollars spent elsewhere. As you can see on the slide, total program expenditures, when it was under the governor's office in 2019, the total expenses amounted to $16.9 million. The program was transferred to CHCC in fiscal year 2022, and in 2024, the total expenses were $5.3 million. Our investments in specialty care are working to pay off. Referrals for ENT, orthopedics, and cardiology dropped sharply, and our oncology center now handles more than 90% of cases locally. When CHCC took over the program, that was truly when we were able to see referral data and use that data to inform our strategic initiatives of service, facility, and medical technology upgrades and expansions. To support all this growth, we have expanded our workforce to nearly 1,000 employees. CHCC is not only the sole hospital and public health provider system in the CNMI, it plays a foundational role in the CNMI's economy as one of the largest employers, a top compliant recipient of federal funds, and a major spender in the local market. In our territory with limited economic diversification, CHCC is both an anchor and multiplier. Our team is our strength, and we aim to continue to invest in the people who provide care for our islands. CHCC's non-provider staff earn a median hourly wage of 20.85 cents, nearly double the CNMI's median wage of $10.82. Additionally, medical providers recruited from a national labor pool earn an average of 127.29 cents per hour, reflecting the highly specialized nature of their roles. The overall compensation of both our clinical and non-clinical professionals helps attract and retain a skilled workforce, injects spending power into the local economy, and helps raise wage standards across sectors. Looking ahead, fiscal year 2026 is a year of further expansion and modernization. We are deepening our specialty and preventive services, especially for chronic conditions and behavioral health. We are implementing our new class-awarded EHR system, which will streamline care delivery, improve safety, and reduce administrative burdens for both CHCC and our patients. And we are continuing to align with our CMS certification and population health standards to ensure our systems are both compliant and community-driven. While we're optimistic, we are also realistic about what could slow us down. Grant instability still remains a concern, especially with federal shifts that affect CDC, HRSA, SAMHSA, and Medicaid funding. Workforce shortages are another challenge. It's still hard to recruit to our remote islands, and the status of our economy is also affecting attraction and retention. Burnout among our professions has always been a concern, but since the pandemic, it remains a national issue. And finally, local funding remains fragile. The Medicaid match, preventive funding earmarks, and support for our health network program or off-island referrals all remain critical and a true vulnerability for us. What we've learned in recent years has shaped how we operate today. We've leaned into partnerships, public and private, and with your help, launched the CHCC Foundation to tap into philanthropy in the long term. We've learned that a healthy workforce is essential, so we're investing in retention, training, and morale. And we continue to right-size programs, break down and prevent silos, and make our system more responsive, so dollars stretch further and patient care improves. In 2024, we experienced changes in our payer revenue mix, with an increase of self-payments and total Medicare and Medicaid cost reimbursements, with a decrease of private insurance. We anticipate a continued shift in this direction, with the closures of businesses big and small, affecting employees experiencing gaps in employment and changes in healthcare status. The fiscal implications for us is significant when you consider that an increase in Medicaid as a payer means only 83% of our costs for services rendered to Medicaid patients will be reimbursed to us. The concern is further compounded when uncompensated care for the under and uninsured is taken into account. Our fiscal year 2026 budget is built around sustaining services and positioning for long-term efficiency. Medicaid and Medicare account for nearly 80% of our patient revenue, and we continue to pursue federal and grant opportunities to complement that. Most of our costs go to personnel, over $70 million in salaries and benefits in fiscal year 2024. But that spending supports local jobs, health system stability, and the expertise to ensure critical services are provided. Key investments this year include, again, the EHR rollout, more facility and medical technology upgrades, and growing our local clinical talent base. Despite our efforts, we face a projected shortfall without additional support. The CNMI Medicaid program operates under a federal cap, and once that cap is met, as was the case in fiscal year 23, the CNMI must fund Medicaid with local funds, leaving CHCC at risk of absorbing those costs. The CNMI's high uninsured rate also means we deliver a growing amount of uncompensated care. Most urgently, we risk leaving federal dollars on the table if the local Medicaid match isn't fully funded. For every dollar in local match, we unlock nearly $5 in federal support. There has been no other steady program in the Commonwealth that turns $1 into nearly $5 the way Medicaid does. Supporting this match is one of the smartest fiscal moves the CNMI can make. In closing, CHCC plays a pivotal role in the CNMI, not just in health, but in jobs and community stability. We support nearly 1,000 employees and contribute over $150 million annually to the local economy through wages and vendor spending. That economic activity ripples into housing, wholesale, retail, education and childcare, service and repair industries, and transportation, to name a few, all of which help families stay rooted here. As for community stability, beyond payroll, CHCC spent nearly $80 million in operations in fiscal year 24. This procurement supports small businesses and generates additional jobs in the community. Facility upgrades like the buildup of our MRI facility and solar installations stimulate construction jobs and strengthen infrastructure. These investments improve care and inject federal, donor, and local funds directly into the economy. In 2024, about 80% of CHCC's income came from outside of the CNMI. Federal Medicare and Medicaid alone contributed about $83 million in payments for healthcare services at the CHCC. Again, CHCC turns these federal investments into local economic activity, funding jobs, services, and supplies that power the healthcare system and economy alike. In the absence of a major private industry, CHCC is not just a hospital, it's a cornerstone of the CNMI's economy. Federal support for CHCC through Medicaid match, grants, and infrastructure funding is an investment in economic stability, local capacity, and economic resilience. Lacking local funding support and cuts to CHCC would ripple beyond healthcare into job loss, business closures, and broader economic decline. Last, your support for our budget, inclusive of the Health Network program, and especially for the full Medicaid local match, is critical. Again, every match dollar appropriated by the CNMI government allows us to draw down nearly 5 times that amount in federal funding. Without it, we risk leaving money on the table and reducing or stagnating care options for our community. Sizus Masi Giliso, thank you.
Thank you, Ms. Eleanor Cabrera and Madam CEO. So at this time, we would open now for questions and answers. But before we do that, let me recognize the additional members that have just stepped in. We have Representative Vincent O'Don also with us this afternoon, and Representative Ralph Yumo. So with that, Madam CEO, I know that your presentation talks about that you have a grants office within the corporation. So how much of grant awards thus so far have been awarded for this fiscal year?
We have our CFO
Okay.
report that.
For fiscal year FY 2025, we were awarded 115,719,000, but that is for performance period ranging between 1 year to 5 years.
Okay, so that's a 5-year funding. Okay, is that all the, is
Federal.
that the total federal grants that have been awarded thus far?
Yes.
Okay, and with these funds, are they used also to compensate personnel with wages?
Yes.
They're flexible to,
No, not flexible. There are program people who are addressing specific program activities that are allowed to be funded under certain federal programs.
Okay. Okay, thank you for that response. And let me shift to H&P, Health Network program. I know that with this fiscal year, the legislature had appropriate 1.2 million for that program. So thus far, since we're entering to the end of this fiscal year, how much of the 1.2 has been used already for the H&P program?
We have received 820,000 of that 1.2. We have expended 3.4 million this fiscal year. Cumulative advances from CHCC since we took over the medical referral program is already up to 3.8 million.
Okay, so with 3.8 million already spent for the program, aside from the 1.2, which you only got 800 from the 1.2 thus far, transferred from finance, right? So with the variance, what are the outside sources that are the corporation is using to accommodate the extra expense?
So the sources are coming from CHC, the hospital revenues.
The hospital revenues. Okay,
Yeah.
thank you for that response. And then part of your presentation talks about CMS compliance, right? And that's very, very important. So when is the next inspection for CMS compliance? And are we, can we fairly say that we can overcome that inspection with all the resources we have with the corporation?
So we've been inspected in the hospital side in last year, September, and they have found actually zero conditions, which
Okay.
means that we've met all the standards.
That's
and-
very,
Now, we did get inspected for dialysis, and there were some findings, but we've submitted the corrective actions, and they've been accepted already by CMS.
okay, that's very grateful to hear. Thank you for that, Madam CEO. And that leads me to my other questions before I open up to some of the members here. You guys, your presentation spoke about the CHCC Foundation, which we actually helped created by law. So with this foundation, how much funding did we actually get out of donations from other investors or companies outside the Commonwealth thus far? Are there any since the creation of this legislation to allow the foundation?
Well, since thank you for the support, with the legislature being instrumental in that ability to help create one. Since then, there's been a significant amount of effort with the forming and norming, creating it as a legal entity. It was just actually granted by the IRS for 501c3 non-exempt status at the end of just last year.
Okay.
And so they're beginning to form and create their policies, and they are in need of more members. So, it had a minimal donation in December, about $5,000. But, they're still in the process of building their board, and so we're hoping that that they can be successful in recruiting more members, because we've certainly already have provided our requests for their assistance for oncology and a number of other project expansions we have. So they're moving in the right direction, not as quickly and not as overnight as we hope with respect to the level of funding we need, but we know they're going in the right direction to assist us long-term.
Okay, so there's a lot of work and efforts are being made as we
Yes,
speak, right?
absolutely.
Okay. And then last question for now. Let me shift to the grants office, right? How many staff running the grants office? And then I wanted to ask about with the awards that you guys have been awarded, right, through your grants office. The corporation holds its indirect costs. It's not actually moved to the OGM office. Is that correct?
So we have a 5-staff grants office management, managing over 50 grants. And our indirect costs, not all of our grants have indirect costs. Unfortunately, those direct benefit to the biggest grant, which is weak, does not entitle us to indirect cost. We receive almost 1.5 million in indirect costs.
And that 1.5 million in direct costs that you guys have received, it's kind of flexible for the corporation, right, to use within the corporation's program. So where do you dedicate those 1.5 thus far indirect costs?
Yeah, pursuant to our agreement with the grants, those indirect costs are used to fund personnel in HR, accounting, grants office, and procurement. And the other will be for the audit and other professional services related to all, cross-cutting to all grants.
Okay, so the 5 employees that are running the grants office are fully funded from this indirect costs?
Indirect costs,
Okay,
yes.
thank you for that response. And I now open it up to the members. If you have any questions. Let me recognize Representative Roman Benavente.
I just have a very short question. Most of it is really common that I like to say to CHCC people that secretary. Thank you for inviting some of the members of and the speaker and some of the members over for the ribbon cutting. No, that was a ribbon cutting ceremony. Not groundbreaking ribbon cutting. For that, I've noticed here in your report that you've highlighted the hyperbaric chamber, which is, this is really, now it's a fruition for the CNMI, because this thing was dreamed since 2013 when Dr. Lamar was here. And we introduced a bill to support the effort of this, to establish a hyperbaric chamber on Saipan and the CNMI. And we did. It will help the diabetes patient and also the divers who has gone diving and have bends. They would be, hyperbaric chamber is the cure for that, really. So to me, I'm very happy that the effort has finally surfaced its task. And Mr. Chairman, thank you. That's
Thank you, Representative Roma Benavente. Further questions from the members? Let me recognize Representative Marisa Flores.
Thank you, Chairman. I did want to go last, but I'm nervous that if no one raised their hands, then this committee meeting is over. So I better just raise my hand and ask a question. I'm just sifting through this huge binder, and I'm just going to go and take up some questions based on the office, and then I'll rest and let everybody else conduct their questions. But thank you for coming. I appreciate it, the CHCC. I notice on your, let's just start with the FTEs. So in your proposal, you have several FTEs for fiscal year 2026, stemming from physicians, staff nurse, medical assistants, different areas of the hospital and the service areas in which they serve their patients, including hemodialysis, family care clinic, medical surgical, radiology, et cetera, et cetera. So on your medical staff, are these mainly for the emergency area? Because we notice on your chart, or at least I did, that there's a big service area in the emergencies. It seems that we're serving more emergency patients than anything else, or not really anything else, but you can tell that a lot of people are going in for emergency care. So are these staff for the emergency unit or other areas?
It's for all areas, emergency and also in the family care clinic. We want to try to, we would love for our patients to come to our clinic versus coming in through the ER. But, unfortunately, sometimes the time, so we've managed to open on Saturdays just to accommodate patients who can't come to CHEC during working hours.
And that's unfortunate because they would have to pay the emergency rate.
Right. We really don't want them to go through there. I
Right.
mean, obviously,
Right.
it's costly and
I noticed that a lot of your outreach has been tailored and reshifted to more of a kind of take care of yourself first before you come to the hospital. You're really encouraging our community to practice more self-care, also be proactive in managing their health, right? I've noticed that a lot, so I would have to commend you on that, mainly because I'm hoping to increase the taxes for Bitternuts, but we're still kind of waiting on that. So, and that is actually tailored to provide more services for the onset, right? Not the onset of oral cancer, but detection, so that we're not addressing the issue on the third and fourth stages, but on the preventive side, which is the first and second, right? So the longevity of someone's life is somewhat taken care of, I guess, in the healthcare arena. You guys are the experts. So these are very huge salaries. And I noticed that in some of the budget detail components, we're also including or the CHCC, I believe, is paying for housing, that is not inclusive of their salary? That's another benefit outside of the gross pay?
So yes, it is not inclusive. And the reason for that is we've been hiring a lot of locums physicians, locums providers. There could be coverage for physicians that are going on vacation, or sometimes we just, hire locums because we can't find someone who can commit to a 2-year contract. So we provide housing, even vehicle, for them to, to have this. But they don't get the benefits, though. They're not entitled to some, no sick leave, no annual leave like that. So
Okay.
So there's a give and take, but they're coming here to provide a short-term need, and so we provide the housing for them because obviously it'd be difficult for them to look for
Okay.
that themselves.
So when you say short-term, it's 1 year, and then they're,
Probably less, sometimes less. Sometimes we even have them cover for like maybe as short as maybe 1 month or 2 months.
okay?
Yeah.
Because, so when that happens, you're only covering that for a period of 2 months. And what subject code or where do you take that from in terms of payment? Because you have on your 6243 rental housing sub-account, we see that there's a substantial amount for housing, but they're at a 1-year contract. So for those that come in on a 2-year period, where do you pay that from?
We don't pay any housing for those employees that are on a 1-year or more contract. We only pay for housing and car rental for the short-term coverage. But throughout the year, there'd be people covering, like for when we perhaps Marty could discuss further the
Sure.
structure on the provider.
Yeah, I mean, it's impractical to expect somebody who's coming to the island for a short period of time to look around for housing, and that won't have bedding or anything in it. And if somebody's only coming for 1 to 6 months, it just doesn't. It's too much of an inconvenience. So in those cases, we remove all of the benefits, and we supply a very basic accommodation. Currently, we mostly use a beach garden and supply a small rental car to get around. But if it's a 1 year or more, none of that is included.
In their salary?
No, yeah, it's just a salary. They would have to provide their own
Okay,
accommodation and their own vehicle.
okay, thank you. Yes, sure.
Clarify, ma'am. Now I figured why you were asking for housing. We only spend about 46,000 in housing for our provider a year. You're seeing 400,000 in there. It's for the inter-island medical referral housing. These are for patients from Rota and Tinian that we provide accommodation for. So the significant portion of the 400,000 budget you're seeing that we are requesting is actually not for our provider. 46,000 for the provider, and the remainder of the 400,000 is for inter-island medical referral.
Okay, and that's why I was going to get to that. I just see it here on this org chart or a sub-account number 62430. There's currently 3 vendors that are listed with dollar amount figures, and they're averaging 1 year. What you're budgeting is for a whole year. So I'm trying to figure out who is getting this benefit because we're also going to be, this is part of what we're going to support. So that's why I was asking, is it a physician? What is it, right?
Yeah, I mean, even the travel there, I think I know that there's about maybe 600,000 or more.
400,000 is
Yeah, I mean, that's really from the inter-island medical referral.
Okay, I'll get to that later. I'm just concentrating mainly on this sub-account number that tells me one vendor gets, you're budgeting 25,200, another vendor gets 12,000, and a one-year lease at 800 a month at $9,600. So I'm looking at the salaries, and I'm just wondering, with their gross pay, let's just take 500,000 for a physician, interventional, I'm assuming radiologist, is that what it is? Okay, at 500,000, I mean, and then yet you're still paying, I'm assuming that you would pay for their housing, no, okay, so that's just it. And then they get other, they don't accrue leave,
Yeah, if you're a locums physician, you do not accrue leave.
okay, and so all of these medical staff are locum, I don't know what that means.
No, well, we budget the medical staff for, eventually we're gonna hire them, but while we're waiting for recruitment and recruiting somebody who's gonna be here for longer term, we go to locums physicians because there is a need.
Okay, and yeah, there is a need. I'm just trying to understand, but thank you. These are big salaries, that's why, and so I just wanted to ask. And then I noticed that you've had some data on your inpatient pharmacy, and there was an increase in the foot traffic. How's that working out for? Yes. That's new, right?
The outpatient pharmacy is new.
It says here inpatient pharmacy. So that's a new FTE on top of what you already have.
Oh, if there is a new FD, yes, because we are extending their hours
Okay.
to work in the inpatient.
Okay.
Yeah.
All right. And how many inpatient technicians do you have currently?
For the inpatient pharmacy, we have about, I believe, 4 or 5 now, but we had we just recently hired one more. So it's been 3 or 4, and then we hired one. In the outpatient pharmacy, there's 4.
Okay.
Yeah.
All right. And so when you provide this salary, the average currently, the median annual wage for a pharmacy technician in the United States is $43,460, according to the Bureau of Labor Statistics, averaging about 20.90 cents an hour. And I notice on your inpatient pharmacy here, you're averaging a gross pay for a new FTE at 115,000.
So these are pharmacists. These are not techs. The pharmacist is usually the doctor of pharmacy. So their average salary is 115,000.
Okay, well, it says here pharmacy technician, so that's why I'm asking.
Oh, yeah, the pharmacy techs are making much less.
Okay, well, it says here, and I
Okay,
just want
okay,
you to take,
okay.
take a look at what I'm looking, and I'm looking at your submission. I'm not looking at anybody else's submission but yours.
Okay, we will correct it.
Okay, so I
Thank
just
you.
wanted, so that is, how much do they currently make us as a pharmacy technician? What is your base pay?
Yeah, you're correct in that error, pointing that error. Thank you very much. So the pharmacy techs is about 30,000?
No, so, yeah, they're not really,
Yeah.
okay.
So just looking at the vacant.
Yeah, it's about 30,000, and then the pharmacists are over 100,000.
Okay, so I guess then in terms of, for accuracy, if the CFO can update this list, because then that really changes your total amount that you're asking for in terms of budgetary planning.
The titles, it just needs to be corrected, but the salary, there's still a need for more pharmacists. Sorry.
Right,
Yeah.
but again, this is
Yeah.
incorrect. You
Yes.
need to update this, otherwise, you know,
Yes, we will do that.
okay.
Thank you.
Thank you. And then let's switch over to the executive office. And this is, I guess, part of your board of trustees, if I'm not mistaken. Okay, let's just go with your board of trustees here. So, under the Board of Trustees, there's dues and subscriptions for 25,000. What subscriptions are those?
That is for the membership under the Governance Institute.
Okay.
And that's for, basically, membership resources, meetings.
So this is for the board to travel? You're paying for the board to be part of something?
Membership to get resources, even for basically just governance, making, understanding how the hospital works and, supporting the hospital and health system.
Okay. Is there a reason why you're putting that under the Board of Trustees request for budgetary funding? And not anywhere else like CHCC's operational or dues subscriptions as a whole?
We're doing it by business unit, so it's it's for the board, so it's going to be budgeted under the board.
Okay. And how many, and with your board composition, how many of them are actually individuals that have some kind of healthcare knowledge?
I would say, considering that some of them have been members for over 4 years already, so I would say all of them have knowledge.
Okay. So do you think that this 25,000 is a great return on your investment, considering that the financial constraints of the Commonwealth government is really tight? Do you think you can bring this down a little bit, or is 25,000 and these subscriptions and dues truly necessary?
I do think it's necessary. I think it's important that they understand their role, especially, and again, some of them are, there is a turnover. We've actually had, in the last 2 years, we've had a turnover in our board. And so we wanted to make sure that they understand that what exactly is the role of the chair. Those are all defined in other institutions, especially in healthcare. So we want to have this partnership to be successful, and I think this is a very good investment for them.
Okay. Because I do believe that creating relationships with your other service provider is important, but I also believe, because there's a high turnover in board, that is the duty of the CEO and other members of the executive team, not the Board of Trustees.
Well, it is a partnership, so we are definitely including that in their budget. I think there's, I think it's necessary.
Okay. I know that there's a lot of boards and semi-autonomous agencies that really, if you have a capable CEO.
Well, let me just mention this, that one of the things that even for CMS, right, it expects the board to have the training and the resources. So this is an investment that is necessary, but it's also required by CMS.
Okay. So I guess my next question is, because you're putting such a large investment in your Board of Trustees, are they able to conduct the trainers in their capacity as they exit out and not renewed?
So again, the board is appointed by the governor.
I understand.
So there's this, and the only reason why we had a turnover was because of, we have a new governor. So,
I understand.
So of course, we want to make sure that we're ready to support them.
Okay, all right. So there's no training on members who have been there longer to new members that obviously should even, okay, here's my question. Do they even understand the basic Robert Rules of Order in terms of board management?
They should, yeah.
Do they is my question.
I think they do. Yeah.
Okay. That's an assumption.
Yeah, and I want to add one more thing. In our CMS Medicare cost report, that expense is actually reimbursable through Medicare and Medicaid.
Very good. As long as it's reimbursed, then that's good. And then you also have a huge amount here for travel, 50,000. Is that for the whole year?
Yes.
Okay, and for how many board members, and where do they go exactly?
They go to they do site visits to the medical referral offices. They also go through conferences, just like any other autonomous agencies with boards.
So board members go to site visits for the HMP program to do what exactly?
To hear directly from the patients and hear what their concerns are so that they can address them.
And how many people in the board have the opportunity to do this? Do you rotate?
Yes, they do.
Okay. All right. Um, you were talking about the HNP earlier, and you have some savings now that you guys are in control of the HNP program. One of the things that was a huge concern for us was Title 75, which was the medical referral program rules and regulations. Have you guys worked on your new rules and regs?
No, we have not.
Is there a reason why?
Right now, there is a request from the community or some, to change it. But the problem is that, and again, it's not savings. When we're talking about savings, we're saving the government. We're not saving that is going to be used elsewhere. This is something that we've expended $16 million before, and now we're looking at really reducing that cost. But the reason why we haven't changed it is because the current regulations actually protects the funding of the program. If it works. The only difference between, the only thing that we feel like we need to change is probably just the title right now of, who's responsible for it. But otherwise, the program allows for utilization of the funding, the little funding that we get, and we ensure that it's fair across the board. We don't, we follow the regulations as is. We determine who's eligible and who's not based on those regulations. And, we manage to maintain that, the cost, to reduce the costs. So if we are going to change the regulation, it might actually cost more, so.
Okay, so if a patient has an individual income over 50,000 per annum, or the patient's joint household income exceeds 75,000, the patient must pay 100% of their air transportation costs. Is that correct? Excuse me?
We have updated that to follow the Hawaii poverty level,
So what is,
which is the
okay.
current one, and that current,
So then you did make some changes.
we made some changes internally, yes.
Okay, I'd like to see those. When did the board approve that?
No,
Who made those changes?
we made those changes, because we needed to update the poverty level, only just because of that section.
Okay, so the board should have made those changes, correct?
I guess so, yeah. I mean,
Okay,
but-
so when did the board make that change?
Well, I don't, is it? Oh, yeah, it's on the regs already that we should follow the Hawaii, poverty level, so
Okay.
we're doing that now.
Okay, so you changed the regs, certain portions or certain areas of the regs.
We've updated just the portion because that portion in the regulation is old, right?
Okay, so section 75-50-315, has it been amended, updated, changed, removed in any, from last year to this year?
Wanna go answer that?
So as far as the income guidelines, it does say on the regs that it refers to the Hawaii poverty level for 2015. So what we've done is just essentially updated it based on the year, because it changes every year. And that's through memo form approved by the CEO.
Through a memo form, okay, so we wouldn't see that. Can we get a copy of that, please, to see those changes? Because I think a lot of our patients that come to us are still looking at this.
Right.
So whatever changes you make internally, we wouldn't know and they wouldn't know. Okay, so, but the CEO claims that it protects the government and we save money from that. So you were talking about, since we're on HMP, you're talking about 400 and some $1,000 and change for medical referral hotels, I assume this is what this is?
The housing that you were referring for are only for inter-island medical referral.
Okay,
The Health Network program covers off-island medical referral.
Okay.
We spend more than 400,000 definitely on housing for off-island medical referral.
All right. So do you spread that out in the 3 islands, or is it the CNMI together? Can you tell me how much ROTA patients accrue in total costs?
I don't have it on top of my head. It depends on who gets sick. I cannot say only 10 people and 10 from Rota get sick. Whoever gets sick shares the pool of the 400,000
Okay.
housing. If the budget is exceeded, we would allow for an overrun to
Okay.
support for housing for our people from Rota and Tinian to get the care in Saipan.
Okay, and that's fine. I don't have a problem with that. I'm just trying to figure out who pays for what. Because when you're looking at the budget, it doesn't tell me that. It just tells me the whole picture. But I need to understand, because when you're coming, when the CNMI is short money, and in order for us to find $12 million so that you can provide adequate health care, it's important that we ask. So, and it also helps us because then now we can look at the municipality and ask the municipality to help us if you're not doing that already. But it's going to come back to us at the end of the day, Ms. CFO. So thank you for clarifying that. I appreciate it. At this time, I yield. I'll ask my second round.
Thank you, Representative Marisa Flores. Are there any other members that have question? Let me recognize Leader Roy Ada.
Thank you, Chairman, and CFO, thank you so much and your team for coming up here. I'd like to just say that, if I like the hospital where it is today and what you guys are doing. I know that you guys are heavily regulated and you guys have to follow a lot of things. So definitely your needs are one of our top priorities. So with that, I just want to just for the public, the viewing public to know, and for us also, is that you requested for 4.2 million for the health network program, which is commonly known in the community as the medical referral. And the governor's proposal only allocated 1.2 million. So what would then happen if you do not get your $4.2 million with the medical referral program or HNP?
Obviously we've spent $3.8 million despite the fact that we got $1.2 million. So we are moving money from the hospital to pay for this. But, we often ask ourselves, do we continue to do this, is considering that the law requires that it be funded, by the local government. So I know it's a tough, we make these tough decisions often, especially because housing is a concern. We don't want our patients to be evicted from these apartments that we're paying for. We have managed to stop the block rooms and shift it to basically renting them as we need them. These are the hotels. And but we do put a high emphasis, basically whatever cash we have, we push it out to the subsistence, because at the end of the day, we don't want our patients also to be hungry and to not have the basic needs while they're receiving care. So we are falling behind in paying hotels. Ronald McDonald House, for example, has past due balance, and they would like for us to be able to take more patients of ours to put them in that housing, because it is like about $75, 56. Okay, yeah, per night, compared to over 100 some in another hotel, right? Especially in California. But, we have to decide on what we need to pay right away, and the highest priority that we pay is really the subsistence. But it does become challenging, and that's when, we come up to the legislature and ask for more funding so that we don't take away subsistence at least.
Yes, I really don't want to see that, and I think everybody feels the same way, where we think that every citizen here, or the community that gets off-island referral, deserves the best accommodations, especially with the conditions that they have, and they need specialized treatment that we do not have or offer here. So, is the 4.2 million would then be for the whole year?
Is that included with the spa?
Would be if sufficient enough for the whole year?
I believe we did not incorporate the spa into this request. The impact of the spa, which is the state plan amendment of Medicaid. So we have discussions with the governor about incorporating it into their state plan amendment to cover subsistence, lodging, and ground transportation, which before October of 2024, Medicaid was not covering that. Medicaid was covering air transportation, but anything else was not. So that has already been approved. The SPA has been approved to be effective October 1st, 2024. We're just waiting for the process so that we can get reimbursed also from that, because we have been using our own revenues to pay for the cost of these services.
I appreciate that, CEO. Thank you for that, because, a lot of our, you guys know it very well. There's a lot of patients that are waiting and pending for, their referral. And there's a lot of moving parts to get them, going. And I just wanted to ask so that we can also, for the body to support, the proposal or the request that you guys are making for the HMP. So thank you for the information. Now you, Mr. Chair.
Thank you, Leader Adda. Just follow through with the questions by our leader. I know that earlier, CFO, you mentioned that thus far from the 1.2 that is have been appropriate for this current budget, 800 some has been already remitted to CHCC. So the remaining balance were, I guess we can assume that you are expecting that in the fourth quarter.
Yeah.
Right, and then you mentioned also thus far that you have already expend 3.4 million for
3.8.
HNP, 3.8.
Yeah.
And then within the 3.8, because the Saipan and Northern Ireland Legislative Delegation has been appropriating also local funds
Yes.
in between. So my question to you is, have you been receiving those local funds that have been appropriated? Perhaps the first one was a couple of months, and the most recent one at 180.
120?
Yeah. So did you guys receive that already, or haven't received that yet?
The most recent one we have not received yet.
But
it's-
the previous one?
Yeah, the previous one we
The
did.
full appropriation?
Yes, we did.
Okay, thank you for that response. And then my next question would be, how much thus far has the corporation accumulated in uncompensated care thus far?
I cannot say the running balance, but I could remember on top of my head that
Just a rough-
2025, the year to date is
Yes.
already 7 million.
7 million for
Just for
uncompensated
this
care.
year.
And with these patients or clienteles that don't have insurance, right? That's why they are categorized as uncompensated care. But for those that of these patients, are all of them outsiders? Because so with these patients, most of them are people, right? So my question would be, does the corporation have a system where a patient comes in that does not have an insurance, that we assist these patients and refer them to Medicaid so that they can get this Medicaid insurance, so that we don't necessarily in the end of the annual year reported as uncompensated. So are there any efforts from the corporation to maybe assign a section within the corporation to catch this patients that maybe perhaps they just don't have the means of transportation to go to Medicaid or and apply this insurance? Are there any efforts from the corporations?
Yes, there's quite a lot of effort, including even patients that do not meet the qualifications in the 75, 50, regulations. We know that Medicaid has what they call the spend down, and which it's like an insurance. An individual may have what they call a medical need, especially if they have, just an event that requires them for hospitalization. So we encourage them to apply for Medicaid and be able to be qualified under what they call spend down.
Okay, so when you say encourage, do you guys like walk them through the process?
We have
or-
an office in our
Okay.
department.
Yeah, I think that's very important, Madam
Yeah.
CEO, because,
Yes.
we don't want, if we make efforts, right, to assist these guys, eventually, in the end of the fiscal year, we'll be able to cut this uncompensated
Right.
care, right, and transform it to
Right.
something that's revenues that's coming to the corporation.
Yes, we have a financial services department. It's called CARA, and we figure out whether they're covered by Medicare, Medicaid. We have the application at our office to assist them, and but there's a lot of people that do not qualify.
Yes.
Unfortunately, I mean, even, and I'm going to mention this because I mentioned this earlier when in one of my discussions with one of our members, is that even just land ownership
Right.
may disqualify an individual, even though the fact that they are not
Right.
they are not working, or so it's
Yeah.
it's really heartbreaking to see that, because they don't have any income coming to them, and
Right.
yet they are, because of the asset that they have,
Yeah.
that is being counted.
Yeah,
toward,
and we are
against
aware
them.
of that.
Yes.
But let's catch those that could qualify, perhaps moving forward. And then that leads me to also, again, Medicaid. I know we've been hearing and watching through CNN or Fox that the big, beautiful bill by the feds, are we going to be affected, or is the corporation going to be, do you envision the corporation being affected by this big, beautiful bill by the feds?
Yes, we envision it to be negative for us. You're going to require, I believe, in 2026 or later, they're going to be requiring work. There's going to be a work requirement, and that would probably reduce some of the eligibility for
Okay.
some of yeah.
So is there any kind of fiscal impact that the corporation, maybe perhaps the CFO can start
Not yet.
working on that so that we can, it's good to know that in advance so that,
Not yet, but I do want to say that I think there is a provision, I may be wrong on this, but I thought there is a provision that protects the emergency coverage for individuals that are uninsured. For example, if they're in the hospital for an emergency need of treatment, they would be covered. But the only challenge that we have right now is trying to, well, not a challenge, but we do need to go back to the table with Medicaid office and make sure that we are actually covered, that they need to put that in a regulation, in a policy that will make sure that we are paid for it.
and our, the current state plan right now, we need to,
It
do we need
covers-
to amend it to kind of,
Actually, it covers already emergency
covers
service.
already?
It
Okay,
just needs to
okay.
be put in place and so that we could get reimbursed for
and
it.
then, okay, thank you for that response. And then last for now, the, congratulations, by the way, for the groundbreaking of the MRI facility. But, so my question would be, when are we expecting this facility to be like up and running?
I'm gonna turn it over to our CEO.
Yeah,
Thank you, Chair. It will be a year from now, so
Okay.
July 2026.
okay, for a year from now. And then, CFO, have we make any fiscal impact as a result of this MRI facility? How much of a savings are we gonna encumber that we are spending right now with HNP sending our patients to Guam just for a simple MRI diagnosis. So have we or has the corporation already assessed that fiscal impact on savings?
We did a white paper on that, but actually we have not done the financial impact on our budget. But we did a white paper on the cost of running an MRI
Okay.
and the reduction in cost on medical referral.
Can we?
And-
Can I
yes.
make an official request that you share that document to this August body? Thank you. Are you for now? Are there any other members who ask questions? Recognize Representative Ralph Yuma.
Thank you, Chairman. Just to, I guess, go back on what you asked earlier as to the biggest financial risks CACC might face because of the implementation of the new one. I mean, how much are we, I guess, just based on your 2024 revenue, Medicaid and Medicare, you're looking at about, I guess, 80 million plus that's going to be affected. Is how much of that is going to be directly impacting CHCC if the new bill by the current administration is going to take effect?
So the timeline, according to what we know about the big beautiful bill, is that it will actually take effect around 2027. So the redetermination will be made into 2026, but it will be effective by 2027.
Okay. Thank you for that. That's good to hear. And just to follow up, I mean, we are going to start preparing for, I guess, cost cutting measures in case this thing takes an effect in 2027. That's what you said, right? 2027. Okay. Is CACC preparing for that, or is there at least a discussion on how to go about mitigating the possible impact?
So we are, like I mentioned in my my introduction, is that we are looking at partnership with other hospitals to reduce costs, but also to try to see if we can generate more revenue through other use of funds from other jurisdictions.
Okay. With regards to other hospitals, I guess I like to look at benchmark as to how are we compared financially, I guess, like versus Guam or versus Hawaii, with regards to the performance of CHCC with your financials. Are we like, is there a benchmark that you look at as to, I guess, how we look at ourselves?
Well, it's kind of hard. I mean, and you may not like to hear it, but it's kind of hard to compare when you're looking at a hospital in Guam, for example, that gets significant appropriation from the legislature. And obviously we get $1 every year, so, and I'm dollar initially, but I know that there's a lot of support through SNIOD and other, you know.
I understand. We're not
Yeah,
affected.
so it's hard to
We
compare,
try.
yeah, because of that.
So my last, I have no issues with, because it's an autonomous agency and the trustees approve of your spending. And it goes through our, just for our approval so that the grants are allowed, are you allowed to spend the grants? With regards to the net patient revenues, how are we looking as to, I mean, when you break it down versus when individuals pay, and is it bad debts included in this? I mean, all those things that are accounted for, is there like a percentage of, like, for example, FY 2026, 2024 at $106 million of revenues? I mean, is there a percentage as to amount that you're gonna actually collect? I don't know if that's.
Yeah. So we base our budget on modified accrual basis. So this is our actually the reported revenues from the prior years are actual cash collections. We don't necessarily, when we're doing our budget, we don't necessarily look at the gross revenue, because our gross revenue is staggering millions, but there are contractual adjustments when it comes to insurance. There are CPE adjustment when it comes to Medicare and Medicaid. So when we do our budget, what we present in our budget in this projection of revenue is the net realizable, which is the cash that we received on the past year and what cash we're expecting to receive. We are not showing you what we're billing
Okay.
and how much of what we're billing is going to be adjusted, because there are several other complex healthcare adjustments, because we are required to bill the same amount for the same services regardless of payer type, but we're allowed to discount it to
Right.
do other insurance negotiations and stuff. So we don't present that because that becomes too complex. What we present is actual cash collections for the prior years and what we are projecting in cash.
Okay, so this is an
Cash.
actual, safe to say we receive 90% of it or more, depending on the discounts of the insurance and all that other, okay, okay. Thank you for that clarification. Thank you, Chair, that's all I have.
Yeah, thank you, Representative Yumo. And then again, just a question on, I know that they approved projected revenues by the CHCC had approved 141 mil, and out of the 141 million, 86 is for personal and non-personal costs is at 54 million. And out of the non-personal costs, 54 million, 3 million actually is dedicated for utilities. So with that, it leads me to my question with regards to utilities. I know that the corporation had some solar panels already in the parking lot there and in CHCC. And how is that helping the corporation with utility bills, if it's even working? I don't know if it's working right now, but I see we see a lot of solar panels there, and we want to know, is it helping with utilities?
It's helping for sure. There's, in fact, we have a report that we were submitting to the board to update them on the savings that we are seeing in regards to power. Water, of course, is still the biggest cost of our utility bill. And so that's something that we are pursuing to see if we can get some, grants or some kind of
Right.
support to reduce that. But
And when you say water, the
like water consumption,
consumption and
because of
also
the-
the water supply for the dialysis also is
dialysis
part
and
of
the
it?
inpatient, yes, absolutely.
And then what's the savings with, as a result of that solar panel program?
I believe it's 30, okay, Mr., yeah, CEO.
Thank you, CEO and Chair. So just a little history. Solar panel Phase 1 project just got connected last year, November 2024. And most recently, Phase 2 was completed and was connected by CUC in April of 2024. So for the last 8 months, we have seen about close to $39,000 of savings. 180 kilowatts have been absorbed by the sun, from the sun to the solar panel. We don't have the battery. We did not procure the batteries to store anything that was picked up by the solar panels. So we are only benefiting during the day when sunlight is available. So yes, almost $40,000 in the
Okay.
last 8 months.
Thank you for that response. But with the solar panels that you have, are they compatible? Should the corporation decide to purchase batteries and kind of beef up some power more to the facility itself?
Yes, it is compatible. And we have another Phase 3 project that will go up as soon as USDA RD approves our RFP, so they can go up for
Okay.
for quotes and then see the fruition. So again, this whole solar panel project is not gonna be 100% because
Right.
again, it's not allowable by CUC's regulation, and
Right.
we will only see base up to phase 3 or even phase 4, about 5 to 10% of our utility costs.
So any reason, is it because of the statute of the portfolio percentage that CUC is not allowing more solar? Any reason? Okay, okay. So, well, this is the body that's gonna amend that statute to allow it, should you guys wanna go further. And then, just one more before I recognize, I know that Rep. Vincent O'Donnell is more expert than me on this, but at one point of time, the corporation was contemplating of getting the hydrogen energy. Is that still on the table or no?
It was on the table when there was funding, there was probably there was potential grants that were gonna be released to purchase it. We don't believe that grant is available now.
Anymore?
No.
So we lose out on that grant?
We were not positioned to apply for that grant at the time.
Okay, thank you for that response, and I recognize Representative
Oh,
Vincent.
He wants to add.
Go ahead.
We did apply for a grant for EPA, but we were not awarded. We missed it by 5 points.
Thank you for that. Oh, man, that was close. Thank you for that response. Recognize Representative Vincent O'Donnell.
Thank you, Chair, and thank you, CEO and your team for being here. And know that we're always going to try to do our best to help out the hospital, and everybody in the CNMI will be, affected in a positive way. So we do understand that power side right now is not the one that's killing you, but it's the water side. And we all understand why, because there's only one water pipe going into the hospital. So how many wells, because this is going to be coming into that budget thing, if you could just bear with me, how many wells are you guys utilizing from CUC to provide water and to put it through the RO unit to supply the hospital?
Thank you for that question. And right now, you can only see one orange tank above the hospital, and that is the well that is connected to supply our RO water. That is the main water source from CUC line. There is still clarification to be made who owns the well, but we have asked, inquire with CUC and BACQ, and the notion we got is that it should belong to CHCC since 1996, somewhere back there. So that's the only well that I'm aware of.
So here's the thing. So is that well sitting on CUC the hospital property?
It's outside the property of CHCC. It has a lot number. I just recall D09. And
Who owns that lot?
good question.
We don't have the title for it, so
We don't have the
We
title.
don't have any.
Okay,
yes,
so
sir.
I highly recommend, because this is gonna, what I'm trying to do is kill this water issue that you're having. You need to work with DPL, or who's that land from DLNR, right? Figure out who owns that, and if we have to create a legislation to give that land to you, and you own that mineral right, and you can dig out as much water as you want, but of course be conservative with it, and then you own the tank, and then you process your own water, and that way you be independent from CUC, which would not have to charge you, but understand that, that water pump needs to be, be taken care of, and your water leaks needs to be under control, because you're gonna be using a lot of power from when you guys complete your, because all of this is gonna tag onto your utilities. And me personally, I prefer that you guys be independent of it, of CUC, and just take care of your own, So we need to figure out how we can get you that land right, and to own that mineral right, and to own that tank, so that the whole thing becomes yours. And you don't have to be tagging on this utilities to CUC and then over to the ratepayers. Because at the end of the day, it doesn't help out anybody but one corporation, and that's CUC. And I don't see how that benefits the whole community the whole CNMI at that. So we need to figure out all of this, and the only way we can figure this out is who owns that land, get that right, and you be the owners, and you take care of it yourself. And that way you don't owe anybody anything. And if we have to introduce a legislation, I'll be more than happy to help you with that. And I'm pretty sure everybody else that sit here will be more than happy to fight for that as well. Thank you.
Thank you.
Thank you, Chair.
Thank you, Representative Vincent O'Donnell. Anyone, any of the members for the first round? Second round, let me recognize Representative Marisa Flores.
Thank you, Chairman. And we've come a long way since last year. Last year was very different compared to this year, but we have a greater understanding of a lot of the issues you face, and utility was one of them. But if we can rezone, then I'm pretty sure we can just even rezone that area to just say that that's public health. I don't know, but let these experts deal with that. That's not my problem. I'm trying to figure out how we can save money so we can pump more money into services, direct services to the patient. So, CEO, on your professional services, there is an increase of $832,000 and change from fiscal year 2025 to fiscal year 2026. In your schedules, like Schedule B, you break it down into each, I guess, division, department, whatever you want to call it. Can you give it to me, please? On the Chief Executive Office, you are anticipating $180,000, or your request is $180,000 for professional services. And that is to contract for a legal counsel, Smarter Good External Fundraising, PHAB, PH Accreditation Board, and Munis annual licenses. Does that pay, does that cover everything?
Is that covered? I think so.
Okay, so professional services, the contract for that, how much is that? Because you have that all lumped up together.
Just a moment.
Okay.
Sorry, can you repeat the question?
Okay, so Schedule B, Chief Executive Office, G101S,
100.
sub-account number 62060, Professional Services. It's listed at 180,000, and then you have these details. Contract for legal counsel. So I guess I'm assuming this is, I don't know, Smarter Good External Fundraising, maybe paying a fundraiser expert, I have no idea.
Okay.
PHAB-PH Accreditation Board, Munis annual licenses.
Yes.
Okay, so for the contract for the legal counsel for the year, how much is that?
Right now, we're paying 60,000.
60,000?
Yeah,
And you're not utilizing the AG?
that is actually from the AG.
So you're paying the AG this? Okay,
Yes, we
we'll
are.
figure this out too. This is obviously another problem. Okay, are there any other areas within the system that pays for attorneys?
No.
Are there any other areas in the system that pays for outside contracting that deals with, let's say, legal or I guess who don't live here but is contracted by the system? Do you pay anyone that does not live here, who used to live here but now lives somewhere else, and you're paying their contract under the system to provide technical service?
About 30,000. Yes,
Okay.
we have someone.
And how much is that?
About 30,000.
30,000. Is there a reason why you can't utilize anyone on island for that service?
She's really, I mean, she provides a subject matter expert, right? She knows She does a lot of research. She does a lot of white paper developments. And, yeah, what's that? And data analysis, thank you.
Okay, so she does all that work.
Yes, she helps us
Okay.
with that.
And then everyone else kind of gathers that data and then shoots it out for,
Right. Yeah.
okay, all right. So you're paying the AG 60,000 from your budget for the attorney representation. And then you're also paying the 1% to OPA, is that right? Why the dreadful face?
Well, it's a lot of money, right?
Okay, so how much?
Receive the invoice.
Okay, so what is, give me an invoice that, Miss CFO, how much did you pay last year?
We did not pay. They invoiced us 1.3 million.
All right, and you didn't pay that.
We didn't pay that.
Okay, and,
We recognize the liability.
okay, so that 1.3 million that you didn't pay, but they invoiced you, where did that money go? You still have it? You didn't pay it? Because it's supposed to be for OPA, but you didn't pay it, so where is it?
Normally, if we receive a general fund appropriation, then we'll give the OPA fee. This is they're trying to get from our operations budget 1% of our operation.
Right.
They assess it on our budget. If we don't make the revenue, of course we're gonna prioritize buying drugs. It's very hard for me as the CFO of the hospital to say for every $500,000 I buy on medication, I have to give 50,000 to OPA.
Okay, so technically, so you use the money to pay for drugs?
Yes,
Or-
medication.
I mean, pharmaceutical drugs.
Yes,
Yeah, we
medication.
wouldn't wanna,
Yes, ma'am.
okay, so that's my question.
Yes, ma'am.
All right, so that's there, that's good. Okay, that's one of another issue that we're faced with is this 1% for OPA. And then in terms of audit, what's the status on your audit?
We just last year they finished our 2019 audit. They're working on our 2020 and 21. We have not yet contracted for 22 and 23. Unfortunately, there is only 2 qualified auditing firm on island. And
Okay.
when we advertised, only Ernst & Young replied. So I believe they're really, really busy.
Oh, yeah, well, okay, anyway, that's a sidebar conversation. How many grants are affected by the lack of updated audit report?
I believe none, because we are working directly with the grants on their peer review audit. I believe our population health, MICA, have been audited directly by the grant, and all of these grant direct audit, program-specific audit were passed with flying colors.
Okay, so none are in jeopardy? All right. Do you have any MOU status FTE, or I'm sorry, not even FTE. Do you have any MOU employees in any of the hospitals, Rhoda, Tinian, Saipan?
MOU from the municipality assigned to us.
Or, well, we've noticed that there's a lot of MOU hire with zero protections that applies when you're talking about violations of labor practices, because it doesn't protect that. No one recognizes it. So I just want to ask, are there any MOU hires or MOU agreements between CHCC Saipan and the municipalities or CHCC in general, period, within the outer islands?
They're no longer with us.
No
but they-
longer,
but they-
so-
But they used to be with us.
So
in
you're
Tinian.
familiar with the MOU?
With Tinian,
Okay.
yeah.
So you don't have that now? All right. And who was paying for that? Who was paying for their salary? CHCC?
No, it's the municipality.
Okay, good. All right. And then you said something about your Munis share. So you are attached to this Munis system here with Secretary of Finance or with the Finance Office?
Kinda, but we have our own server. We're no longer sharing the server with the Sinamay government. So, yeah.
Okay. What does that mean
We,
exactly?
we used to be under the JDE that is
Yes.
housed in the central government. So when they turned that off, we had no option but to join them when they did the munis.
Okay, so how much are you paying them?
The
Your share?
the annual contract is about 120,000.
400
100.
Oh.
120,000.
120,000. Okay, so you pay them this
We pay directly to Tyler Munis.
to Tyler Munis. Okay. So then you have the modules all set up for you the same way that, well, not really the same way because they're not up to date yet. We found out this morning. But your systems are already set up
Yes.
by module
Yes.
and what it offers on the Tyler Munis.
Yes.
Correct? Okay. So if we ask for report generation activities for any year, you can pop that up and just tell Munis what you want and you can get it out.
There are some limitations to that, some programming limitations, but yeah.
Okay, one of the things that we spoke about in the 2025 budget hearing was the your high receivables. Has that been taken care of? Are you using outsourcing a collection agency now? Have you,
No, we're not.
how much in receivables is still owed to CHCC?
Do you have that number? We can provide that number for you
Okay.
later.
All right, because we see a lot of the expectation and the anticipated revenue, but we don't know what your other stuff are. I guess what we call the incidentals that just are not anticipated. I guess off the top of my head, is that going up or is that going down?
Our receivable is trending the same as the prior years. So of course it would accumulate up if it's trending the same.
Okay, so I guess in numbers, more than 500,000, less than 500,000? 1 million?
More than 1 million.
10 million?
Let's make that an official request to this August body if you can
Yes.
submit the accurate number
Yes.
on that.
Thank you, that would be great, so we know what's anticipated. I think that's it for me. Thank you, CEO, thank you, staff, for coming out. Chairman, I yield my time.
Thank you, Representative Marisa Flores. So just one question before we wrap up, Madam CEO. I don't know if it's, what is it called? Is the settlement agreement between CHCC and CUC still effective?
We are waiting to sit down and actually have another MOU or an
Another
agreement.
MOU.
Another
So the
agreement.
recent discussion, or you guys never strike an agreement?
They have proposed, we counteroffered, and they have not accepted the,
So what's in the table right now? What's the capabilities of the corporation in paying those arrears? What is that range right now?
we were asking for 50,000 a month.
50,000 a month, okay.
On top of the current bills that we're paying already.
That you're paying currently?
Yeah.
Right, okay. Thank you for that. If there's no more questions from the members of the committee, Madam CEO and your team, on behalf of this committee, we extend our gratitude and appreciation for all of you guys for coming before this August body to discuss your budget requests and also the proposal that the administration had sent to the legislature back in April. So with that said, I will give you back the floor for any closing remarks before we adjourn. You have the floor.
All right. Thank you so much again for the opportunity to speak to all of you and for the great questions that you guys have given us. I think it definitely puts us to task to make sure that we get these reports to you. I know that you are, there's obviously some need to kind of enlighten on what exactly and why we need this funding for our system. And we appreciate the partnership. Again, I know that, like I said, times are challenging, but really, if there is additional funding somewhere, please consider, because it does go directly to patients. yes, we talk about personnel, we talk about non-personnel in our budget. That is a little, I mean, it's obviously a lot, but it does go to patient care. We are competing with next door in Guam, and we would like to retain our staff. We have amazing staff that are really, really care for this community. Again, I mentioned earlier that they are really advocates of our patients and our community. And, they love it here and they would like to stay. So we would like to be able to keep them as well and making sure that we are available again and accessible and making sure it's affordable for everybody. So thank you again for your time. Appreciate it.
Thank you, Madam CEO. So with that, members, we move down to our next order of business, which is item 6, announcement. And at this time, the chair would like to announce to the viewing public and remind our members that on Friday, the 11th, we have the Department of Commerce before us at 9:30. So with that, we are now on our last order of business, item 7, adjournment. And at this time, the chair adjourns this budget hearing. We are now adjourned.